personally, I've always had an interest in the therapeutic relationship in treatment of any kind of psychiatric disorder, but then specifically in dealing with suicidal patients. And together with my colleague, who is a psychologist, I'm a medically trained person, and that's quite important because the psychologist tells me, you medical people, you've never learned to understand why people act. And suicide is not a symptom of a disease, but it's an act or action. And there's something called action theory, which means actions are goal-directed, they make sense for the person, and the way we explain actions is through narratives, telling stories. So we started with this work with clinical interviews where we compared a usual clinical interview with a narrative kind of interview. Narrative kind of interview means interview that's where the opening question includes something like story. Can you tell me the story behind it? Or I would like to tell me what is behind a suicide attempt. And that means then you have to trust in the narrative competence people have. They can explain what is behind it. 9 out of 10 patients where we do these narrative interviews have an excellent, impressive narrative competence. So what they would usually, the sort of pattern we see is that they would say, well, 2 years ago there was this and this, had a crisis, went to see a doctor, psychiatrist, took some antidepressants and things were okay again. And then the same thing again, let's say separation happened again. My boyfriend just left me like this without explanation. And I got into this crisis, didn't see any way out, made a suicide attempt. But you know, actually, it goes right back to childhood. That's the kind of pattern of the narratives people use. Yeah. So that's the basis of this ASSIP, that what we found then in this study where we compared the two approaches was that the therapeutic attitude, as rated by the Penn Helping Alliance questionnaire, that's an instrument where patients fill in some 11 questions. Okay. That they have to answer questions relating to the therapeutic relationship. And it was clear that those people who had a narrative approach, that they rated the therapeutic relationship significantly better than the other ones. So we started from there. And then we felt that if, like this, we can relate to these suicidal people in a much more meaningful way than what the usual clinical approach in hospitals or emergency wards is, then this would be probably a better basis for intervention, also to help to reduce the suicide risk for people who have attempted suicide. And I don't think I have to mention this here, that after attempted suicide or attempted suicide in your history is the main risk factor for suicide in the future. Right? So we felt we wanted to concentrate on this population at risk. So that's how we developed this program. And so in the first session, we do this narrative interview. It's video recorded. In the second session, we sit together, side by side, with the patient, watch the video, or at least part of it. We don't usually watch the whole video. And we tell the patient, if you want to add more information, please stop the video, tell us, or I would stop the video and ask the patient, can you tell me more about this? It's just a way to deepen the narrative, the information, and what we always find is that the story makes sense. It's logic for the observer, for the interviewer to follow the development, the process, that the person ends up in a situation where he or she has no other choice than just doing this. And then in the second session, we give people a handout. It's a 4-page psychoeducative text where we describe the meaning of mental pain, of in in the suicidal crisis, people often have dissociative symptoms, about dissociative symptoms. And if I can say that, many people we see say, I don't really understand how all of a sudden I got into this change, into this state of mind, which was not myself. It was not myself doing this. And after they have read this text, and they are asked to make remarks and to add their comments and then take it back, they very often say, this has helped me to understand. And I've shown this text to my husband or whatever, to the family, and we have discussed it because it explains what happens. And there's also a short section there about the neurobiology, that your brain, when it's under stress, that you're no more able to think rationally, but it's emotions taking over. So that's a way to establish a common model, which is an important aspect for any psychotherapeutic intervention, be it cognitive, behavioral, or whatever. And then in the third session, in the meantime, we prepare a summary of what got them what's of the story behind it,
Right.
which includes the vulnerability, what's the specific psychological and biographical vulnerability of a person, and what is the trigger that actually triggers a suicidal crisis. That's just one page, very short. And we sit together with the patient and we go through it sentence by sentence, making sure that it's okay for the patient, and we correct it and revise it accordingly. And then on the second page, we work out together with the patient, and we include some of the information we got earlier, some of a summary of the warning signs. What are the first signs that things could get critical again? You know, let's say sleeplessness, or feeling totally inadequate, circling of negative thinking. There's no thinking that this cognitive schema that we know from cognitive behavior therapy. And then what are the warning signs? What are the strategies you can use? First of all, your own strategies, and then second, strategies involving other people, like maybe your GP, your therapist, or if there isn't any, you call the crisis line, you go to the emergency ward directly, things like that. It's all worked out very clearly with names, phone numbers, and so on and so on. And we have this small, and then out of this we make this small size, sort of credit card size folded paper. We call it a leporello. Some people know what a leporello is. Leporello comes from the Mozart opera, the Don Giovanni, where the servant of the boss of Don Giovanni has a list of all the women that Don Giovanni conquered throughout the life, and he opens it like this.
Okay,
it's a folding thing.
Folds out.
So we have a system where we sort of copy-paste this what we worked out with the patient into this small size.
The individualized summary and plan.
Right.
Is in this little fold out.
Right. And on top is the name of the patient, and then we have the strategies, and they're meant to keep it in their pocket. But I can tell you, when we see these patients, let's say 2 years afterwards, I ask them, do you still have? And they all take it out, say, of course I carried it with me all the time. And sometimes when we see them after 2 years, we have to revise it because certain things have changed. Maybe it's not the same GP anymore, and so on and so on. So they get this. And the summary is also meant for any other health professional that's involved. If they're inpatients, we give them the copies for the responsible therapist. If they're outpatients, maybe they decide my GP should have a copy of this, my therapist, my psychiatrist, or whatever should have this. And then the fourth session is a re-exposure to the suicidal crisis. We take the first narrative, the video recorded narrative again, watch together, and say, now we go through it again, and you tell us at what in what moment would you do what kind of, apply what kind of strategy to stop the process. And sometimes people wait quite too long before they react, and then we ask them, why didn't you say that you would do this and this? We discuss it, and when we have a rerun, we do it again, to make sure that they can say, here, I must take my phone, I must call somebody, things like that.
Right.
So that's the program.
And how's it working?
It's working very well. We have had a 2-year time just to get used to it and to develop it, and we have just now presented the first results after 12 months, the follow-up evaluation. In this study we have 2 groups, 60 patients each, the intervention group and the control group, and the result is we're quite impressed ourselves. In terms of attempted suicide, in the follow-up period, we have 2 attempts in the intervention group of these 60 patients and 25 in the control group. The 25 have been performed by 11 people making 25 attempts in this time. 60. And this is something like 19% of these 11 cases are something like 19% of the group, which is about the average which you would expect from a normal population after attempted suicide with treatment as usual. So it's quite in the range of treatment as usual.
Who is delivering these 4 sessions? What kind of staff are doing this?
It's a psychologist who is mainly doing it with me. It's partly done by me, and we have 2 or 3 psychologists who now apply this. And there's a funny one thing I didn't mention actually. The 5th element would be the letters we send for 2 years. That's an important part. Because there are these studies showing that the
caring letters,
so-called caring letters, which you send, that they have an effect. And our assumption was that if we establish a therapeutic relationship with our program, these letters should be more effective because they are signed by our name. People know where they come from. They know the person. We actually get a lot of feedback. People very often send emails back. They're invited. We say, it would be nice to hear from you, but you don't need to send us a letter. But so we have this ongoing contact with, I would say about half of these patients, they send us feedback normally after the letter. So the letters in the first year are every 3 months, and in the second year just every 6 months. And so this is an important point, right. And that is related to the follow-up study because we want to wait for 2 years before we do the final publication of the results. So we just have the 12 months now. In spring next year we'll have the 24 months follow-up. Yeah.
This seems like a relatively simple model that people could pick up and replicate. Is anyone doing it yet outside of the psychologists that you've trained?
Yeah. Yes, we're very pleased with that. The Finnish Association of Mental Health has adopted this program. They've come to Bern in Switzerland where we do this, and they were convinced that this is a useful model for them. And they've just started actually about 6 weeks ago. They've already included 20 patients in these 6 weeks. And we did give them, of course, the initial training, and we'll also do some supervision. But they say it's very easy to adopt. The main thing is to learn to do narrative interviews, which is the different role of the health professional from the usual one. And I say, as a psychiatrist, when I talk to people after attempted suicide, I have 2 different roles. The first one in this narrative interview means that I have to listen to the patient's story, and this means the patient is the expert of his or her story.
I love it.
I don't know it. I have to listen and just be there and believe that this person can tell me the story. But when it comes to collect or to exploring about symptoms of depression or whatever, and making a diagnosis and working out a treatment plan for a psychiatric disorder, then I'm the expert. That's very clear. But these are two different roles, and most health professionals are not used to the first role. They have to learn it, to just sit back, and I tell them, you have to, first of all, to believe and to trust in this concept of suicide as an action and not as a symptom of illness. That patients and people every day in everyday situations, we explain why we do this or that in terms of stories. We would often say, if someone asks us, well, this is a long story, and we start there and there. But if we trust that people have this narrative competence and that it's a natural thing to do, then it works. Yeah.
What do you think's the magic about this? What's the component that, I mean, there's so many exciting parts, the engagement, the collaboration, the brief nature of it. But this narrative piece of them watching that video, what do you think makes that work so well?
I can refer to Dave Jobs' collaborative model. In fact, when I, years ago, more than 10 years ago, no, it was about 12 years ago, I was at the Houston conference of AAS, and Dave Jobs gave the plenary talk there. And he showed this picture where he says, traditional model, patient and doctor sitting vis-a-vis. Collaborative model, we sit side by side, and together we watch the patient's suicidality. And then I went up to Dave Jobs and said, hello, I'm from Switzerland. That's exactly what we do. In the second session, we sit side by side, watching this video. And I think this is also a way of, demonstrating to the patient that we are joining him or her in this story, in looking at the suicidal process. We're not the experts. We're sitting side by side, just like the collaborative model that Dave Jobs uses.
We've had a hypothesis in the United States that many behavioral health staff, clinicians and others, are so afraid of this topic that they're likely to refer the person to a psychiatrist, a mobile crisis team, to an emergency room, and they in turn refer them on, and they frequently end up being hospitalized. Yeah. And it's been our hypothesis that if staff had the training or a model where they were more confident to actively engage in these discussions, actually, ironically, the hospitalization rate would come down. Sure. Some have said that it would lead to higher assessment and more hospitalization, but we don't think that's the case. What's been your experience with?
I told you that in this follow-up, of course, we looked at various variables, not just the number of attempts. And one thing which came out clearly was that the intervention group had fewer days in patient treatment after the attempt, and within the 12 months, significantly less inpatient days. And also partial hospitalization was less. And in fact, we also found that there was a correlation between the inpatient days and the Therapeutic Alliance scores in the Penna Helping Alliance questionnaire. That the better the patients rated the Therapeutic Alliance, the less inpatient days they had the inpatient treatment days they had.
Magnificent.
So, so that's another part we're looking at and which we're going to publish, the role of Therapeutic Alliance. It actually makes a big difference. It's one of those moderating variables that influence the course of events after the attempt also.